Good afternoon, all. First of all, big thanks to Dr. Vitul and his team for inviting me over. And today, topic of my presentation will be mucormycosis. And I suppose that we all are sitting here from different branches. So I'll keep it a bit generic. I'll try to keep it a bit generic. There are some detailed parts of here in this presentation in which the typical hardcore ENT would be interested, but we'll skip that and we'll continue to get an overview of what is mucormycosis and how it hit Malwa region. So for most of us, this term mucormycosis, we came to know about this term during COVID pandemic, when certain number of cases started to increase to a paramount that our health system kind of crumbled. Newspaper even labeled it as a mini pandemic within a pandemic of COVID-19. So what is mucormycosis? Let's have a brief introduction. It's a fungal infection. Most common agent of this is rhizopus and mucor. This is a life-threatening disease most commonly occurring in immunocompromised patients. This fungus is ubiquitous in nature. For example, right now this fungus would be around us in this auditorium because of the humidity. If there is some humidity or moisture around, the spores of the fungus will be there. So, whom it affects? It affects a person with immunocompromised status, with altered diabetes and all. Uh, it occurs through the inhalation of sporangiospores, and it has an unacceptably high morbidity and mortality in patient with the disseminated disease, and it was not so uncommon in India. Even before COVID-19, I was in PGI Chandigarh. We used to see a lot of mucor patients, mostly from the Punjab region and the cultivated areas, but it was not as highlighted as it was later. So, as I said, it was this study was of before the COVID-9 and COVID-19, and it was not so uncommon in India. India had a higher incidences of mucormycosis. Predisposing factors are most commonly patient having high diabetes mellitus with ketoacidosis, prolonged corticosteroids, and other immunocompromised status. Here we can see major chunk of the patients which are predisposed to mucor is diabetes and having ketoacidosis. The types of mucormycosis, mainly most commonly orbitocerebral, which is most common, followed by pulmonary and cutaneous. So it is most commonly occurs by Rhinospora oryza. Inhalation of the spore is the most common thing. What is the main pathogenesis? This fungus causes vascular invasion and thrombosis of the endarteritis. So ultimately it causes a necrosis of the adjoining structures. It can occur at any age. Symptoms initially presents at acute sinusitis, which is rapidly progressing and spreads to contagious structures. Palatal ishar and hallmark is black necrotic issue in the inferior turbinate region or over the skin of the face. It is the typical of the patient having diabetes and a fixed globe. This kind of a picture is a typical pathognomic. You can tell when you see this patient that this is probably mucor. Orbital involvement is quite common because orbit is near to the paranasal sinus. So from there on, the fungus goes to the orbit, which causes initially it causes periorbital edema and pain and proptosis, and later on it progresses to ophthalmoplegia, which causes due to infection of muscles and orbital space, and later on flows a frozen on globe, and which leads to decreased vision or vision loss. So clinical staging depends upon the extension. Nasal mucosa and sinuses causes stage 1, stage 2 is orbital involvement, and if it goes to brain, it is stage 3. Diagnosis is basically high index of suspicion. Any immunocompromised diabetic patient comes with the features of acute sinusitis or having a necrotic thing around the nose. We should take a biopsy and a fungal smear. Nasal endoscopy sometimes can be very subtle in early stages, and later stage of flank, we can see the black necrotic issue and septal mucosal discontinuation. The most common how we diagnose it, Mucormycosis, most importantly, we should keep in mind biopsy is not the diagnosis. Okay, biopsy will come in 3 to 5 days. We cannot wait for treatment for mucor for 5 to 3 days. Fungal smear, it's a KOH smear. It is done in half an hour at our center at AIMS. If we send a report, usually within an hour, we get the report that this patient contains a broad aseptate hyphae in that mucosa. If the typical patient is having broad aseptate hyphae, we label it as a mucormycosis and start the treatment immediately. Other biopsy can be done, but it will only delay the treatment. Culture and molecular diagnosis can be done. Imaging studies is only not for the diagnosis, it is to know the extent of this disease and to delineate your surgical plan and further prognosticate the patients. These are MRI findings. MRI is most commonly done to see the cavernous sinus involvement and the intracranial involvement. Approach to the treatment, it is basically four factors. First of all, we should make our diagnosis very rapidly and we should reverse the underlying condition. For example, if the patient is having diabetes, we should control it. If the patient is on prolonged corticosteroids, we should stop it, or other so and so forth. And start of appropriate surgical debridement of the infected tissue. Why it is appropriate? We cannot debride each and everything in the skull base because it has a vital structures. So we have to take a clinical decision on a very precise pattern. We'll debride this much of the tissue and we'll leave this much of the tissue because obviously because it is near to the orbit, near to the brain and other vital structures, and appropriate fungal therapy. So usually if the patient is diagnosed within 5 days, it has a very good prognosis. Survival markedly decreases if patient responds or presents later than 5 days. Reversal of underlying disease, we have already discussed about. We have to manage diabetes and reduced corticosteroids and other things. Best treatment is combination of surgical debridement and antifungal therapy. Surgical debridement, should be the timing of the surgical debridement? When I was in PGI and I was training, so we used to say that sun should not ever set over the mucus. For example, if the patient has came to mucus in the evening, 5 o'clock, we should get it debrided in the night only. We won't wait for the next day. We get the diagnosis done and we get the surgery done. So surgical plan, it should be aggressive. Excision of the local lesion, it prevents further spread, it decreases fungal load, and affected tissue rarely bleeds. Surgical procedure continued till normal, well-perfused bleeding tissue is observed. So these are some pictures of surgical debridement with lesions which is gone beyond the palate. This is orbital exenteration. In intracranial spread, disease is very aggressive. The patient is usually have very high morbidity, generally disfiguring, but surgery has to be done. Sometimes if the disease is very aggressive, we take the decision against the surgery because sometimes we cannot save the patient. These are the recommendations. I'll not go into the details because now first line of treatment is liposomal amphotericin. There is so much in the COVID pandemic. There was so much fuss about what is liposomal amphotericin, what is conventional amphotericin. Basically, conventional amphotericin is not liposomalized. So what it does, it is more nephrotoxic. Otherwise, this conventional amphotericin, deoxycholate, is a good drug, but we cannot give it as a prolonged therapy because it generally causes nephrotoxicity. So liposomal amphotericin is a lesser nephrotoxic drug. So patient acceptability is more. We can give it in high doses and we can maintain the serum level of amphotericin very high, which causes fungal disease to initially control. So it is the drug of choice. Liposomal is the amphotericin. Major liposomal amphotericin issue was its cost constraint. During pandemic era, this one vial was usually its print rate was 5,500, and in black marketing it was one vial was going up to 35,000, and one day therapy is 4 vials. So you can say that patient के साथ क्या क्या हो रहा था. 1 लाख रुपए का तो ट्रीटमेंट पेशेंट को एक दिन में कहीं से लेना पड़ रहा था. तो इट वाज अ ह्यूज ह्यूज क्राई. So this was details about lymphotericin. Other drugs, azoles, we use at a step-down therapy. Posaconazole and isavuconazole are two broad-spectrum antifungals which can be used. Other antifungals like voriconazole and fluconazole are not effective. These antibiotics are available in oral and parenteral form. Posaconazole monotherapy cannot be recommended as a primary treatment, but it act as a step-down therapy. For example, we have given amphotericin for a month. We have given around 3 grams of amphotericin. We can step down as a on posaconazole. Isavuconazole is a newer drug. Pfizer has launched it with the brand name of Cresemba. It's a costly drug, but it has a good bioavailability. It has excellent oral bioavailability, not reliant on food intake or gastric pH. It is effective against invasive mucormycosis. IV isavuconazole is water soluble and renal safe. Step down. So, as I've already tagged down, these are mainly used as a step down therapy. Duration of therapy, because the mucor is a primary disease of India, so a lot of detailed studies are still not there. So there is no definite period or dose of mucor liposomal lymphotericin. We at AIMS, what we follow, if the disease is not intracranial, we give around 3 grams of amphotericin. If the disease is intracranial, we give around 5 grams of amphotericin. Otherwise, till the resolution of the clinical signs and symptoms and radiological resolution of radiological and clinical signs of active disease. Usually takes around 1 month to 6 weeks of total treatment. Hyperbaric oxygen can be given. It is given in the literature, but it is available at very few centers. I think only one center in Punjab and one center in Delhi. This is the treatment recommendation. We start with amphotericin and we step down on posaconazole. So during the time of, now will come what we did at AIMS Bathinda. During the time of AIMS mucormycosis, AIMS Bathinda was not fully functional. We just had an OPD and we had a swarm of patients coming to the OPD and we were not able to do anything. We were referring every patient to the PGI, and PGI has locked the doors of mucor patients because they were whole of the patients of Punjab was going to PGI, and they were not able to operate patients. Not amphotericin was not available. So I went to director sir कि सर कुछ करते हैं यहाँ पे. सर ने कहा हम यहाँ क्या कर सकते हैं. तो सर ने कहा जो तुझे चाहिए तू कर. So what we did here is we converted our blood bank into a mucor ward. There was, because we didn't had our wards at that time. We didn't had anesthetist. So we went to civil surgeon sir, Dr. Tejwant Singh Dhillon. मैंने कहा सर हमारे पास anesthetist नहीं है. So he told our anesthetist will come, you operate. And this was the first time that, I don't know, AIMS, central agency and state collaborated in a beautiful way, that anesthesia person used to come from civil hospital, and team at AIMS AIMS Bathinda used to operate, and we operated continuously for 3 months, daily mucor cases. So that is our kind of story, and so our experience, we operated till now, we operated more than 300 of cases. Some patients were already operated from outside, few patients were operated, most of the patients operated primarily here. Some was, one case, one surgery was done outside, and then we took up the surgeries. Some patients were like, they all got operated at DMC, वहाँ पर treatment मुश्किल था, obviously expensive था, they shifted here. We published in very high impact journals also. So why mucormycosis in Punjab? So this is the data of 2022. Here we can see that continuously patient was there from January till November. There was, every time there was patient admitted at AIMS Bathinda. But in 2023, there was a sudden, you will notice a sudden upsurge in October and November. There we alarmed central agencies. I don't know what has happened, but recently there are cases started to rise in mucormycosis. Our wards were full with mucor. So there was a report published in Times of India, and whole of the central agency got alarmed, and they sent a team to investigate at AIMS Bathinda that is it really true that mucor यहाँ पर इतना है, otherwise ये ऐसे ही कर रहे हैं. So two teams from state and center came us to visit, and they investigated that Punjab is basically the capital of mucormycosis, because in that era, in that year 2023, AIMS Bathinda had the highest number of cases in entire India. We reported around 112 cases, which was not there. So this was the data in Punjab, where the cases, you can see the line listing of cases, where you could see AIMS Bathinda at the highest, followed by DMC, and we were seeing cases from entire Punjab. We can see right up to Ambala, Saharanpur, Muzaffarnagar, Sarsa, Hanumangarh. These are the patient and line listed of the patients. So here you can see, if I can marker, how can this is. Yeah, how can I mark over there? This blue line is showing 2013 data, and here you can see sudden upsurge in the cases of mucormycosis. In lower graph, you can see this blue one is 2023 and orange one is 2023, and sudden increase in number of cases there. This is the number of cases. How many times left? 5 minutes? How much time is left? Here we can see this is the, as we compared our data to PGI Chandigarh, PGI was already having high number of cases than us, but in later part of 2023, AIMS Bathinda started to have number of cases. The whole of the Punjab, the kind of we had a mini pandemic, mini epidemic of mucormycosis. Of this, Bathinda was an epicenter. One epidemiological team from Delhi came and investigated this matter. What is happening in Bathinda and what is there is there. So what they found out to be, most of the patient here was having diabetes, and some of there was having hypertension and renal factors also. Other mostly patients were farmers and belonged to rural population. And what they came interesting, what finding one was there, cattle breeding was very common around that area, and farming, for example, cultivation of farms. So these two things were very common, and uncontrolled diabetes. These things were very commonly found during these patients. Uh, Types of diet, food practices, these were not very correlated very clinically. These are the patients which listed at AIMS Bathinda. So these was the symptoms: headache, facial swelling, facial pain, blurring of vision, loss of vision, periorbital edema, nasal congestion. These are most common symptoms. Few patients were pulmonary, having shortness of breath and chest pain. These are the few patients. This is a young male with uncontrolled diabetes came to us. We operated on this patient. This patient went fine, but after discharge, this patient developed intracranial abscess. You can see an intracranial abscess. Usually such patients have a very bad prognosis, but our team went in to operate this patient, and this patient ultimately survived and was perfectly fine. I think this video will not, this patient is speaking, telling his name. Now he'll apply a palatal prosthesis, which I'm showing in this. He'll apply the prosthesis and he'll be perfectly speaking then. Audio is not coming, I'm really sorry about that. This is, because his whole of the palate is gone. Now this patient is fine, speaking fine. This patient also, we did a complete palatectomy, and after that, you can see we applied, our prosthodontist department applied a palate, and this patient is living an almost normal life. This is the patient, we did a endoscopic debridement 3 times. All endoscopic, no external scar, because she was a female and she had an issue that she should not have a scar over her face. We operated. There's a non-diabetic, few of the cases were non-diabetic also. There's a young male with a non-diabetic patient with no immunocompromised status, was just had mucormycosis. These were one of the sporadic cases were there. This patient with having orbital mucormycosis along with the pulmonary thing going on. This patient has a follow-up. This patient has, you can see, has a ophthalmoplegia. But his eye is preserved, but he has a permanent ptosis, but he's perfectly fine, cure of disease. He's coming to regular follow-up to our patient along with his wife, and this is one of fewer patients. This patient we had to do a orbital exenteration. This was completely endoscopically done. We did this patient endoscopically with no facial scar, perfectly fine. This is a female patient, also done endoscopically. This is a patient done endoscopically. Ophthalmoplegic patient, done as endoscopically with not orbital exenteration, not done. One more patient. This is a patient, we lost this patient ultimately. This is a cutaneous mucormycosis along with rhino-orbital mucormycosis, presented very late. We did operated on this patient, but subsequently this patient succumbed in ICU. This patient is typical ophthalmoplegia. Later on, this patient also succumbed. Another patient which we did endoscopic procedure, young patient, a diabetic patient, we had to do an orbital decompression of this patient. So how we troubleshooted? As we already said, we converted with help of our director, sir. He was very helpful in each and every step. We converted our blood bank into a ward. We continuously requested central agencies to give us amphotericin, and we coordinated with state health agencies for anesthetist and amphotericin to an extent that our DGHS, Director General Health Service, New Delhi, has passed a ruling. If somebody in all over India has a short expiry amphotericin, it should be directed towards AIIMS Bhatinda. So we alerted the ministry like that we are only having cases of mucor and please give us liposomal ampho. So this is a letter where you will see that we are getting ampho from Patna and Ranchi. This was short expiry. If you see, this letter is dated on 7th March. तो मिनिस्ट्री आस्क कि 7th मार्च की एम्फोटेरिसिन है, आप लोगों को अप्रैल या मई में एक्सपायरी हो जाए, डू यू नीड इट? We had 12 patient, 15 patient admitted in the ward. I said yes, and we were able to consume that. And ministry is also happy about that. I'm just posting this because most of us will be working in a health setup, in a government setup. If we keep on pressing the authorities, if we keep on telling them, okay, if we keep on telling authorities that our patient needs this, authorities are always there to help. So this is our team going to Delhi airport, especially to get amphotericin. These were the recommendation, the sensitizing the ENTs and physicians for early diagnosis, making diabetic clinics to control diabetes, making treatment available more widely, and provision of a mucormycosis registry. Thank you so much.
Thank you very much, Dr. Vaibhav. What you did was exemplary, in fact.
Thank you, sir.
And I think you had the main number of cases unparalleled as far as India is concerned. So I must appreciate your effort, supplemented by the great man, Dr. D.K. Singh, as
Yes,
he is.
Yes, sir.
And he was instrumental in motivating many other people, giving you the free
sir.
hand to treat.
Yes,
So
sir,
we are missing him today also. If would have been here, most of the students would have been here.
Yes.
So thank you very much.
Sir, director sir was very helpful in each and everything.
He is an excellent personality.
Yes, sir. Yes, sir.
And we wish him early recovery.
Yes, sir. Yes, sir.
Yeah. Thank you.
Thank you so much.
Very
Thank
much.
you so much, sir. Thank you so much. Yes, sir. Yes, sir.
So we should understand that mucormycosis will affect when the patient is immunosuppressed due to anything.
Mostly, sir.
That,
Mostly.
like steroid therapy or like it was COVID season and diabetic, uncontrolled.
Yes, sir. Yes, sir.
Yeah. Okay.
And so most commonly young patients with on dialysis, they are also very immunocompromised and predisposed to mucor also, sir. I've seen one patients, उनका daily parallel diabetes होता था, both 30-year-old chaps, दोनों का एक ही हॉस्पिटल में भटिंडा में डायबिटीज होता था, and both got mucor at the same time. So there is lot to study and lot yet we have unknown in mucor, because it is not known to be infectious disease. It is not called to be infectious from one person to another. It is not known. But we had a patient admitted. We had a mother and a son admitted here. Mother को म्यूकर था, 5 दिन बाद son को भी diagnose हुआ. But right now, till the now evidences we have, mucor is not known to be infectious. So lot of things which is yet to be unknown, I would say that in mucormycosis. Thank you.